Hello, everyone, and welcome to today's virtual interactive panel discussion brought to you by Northern New England. My name is Rachel, and I will serve as your ACHE technical host for today. Before we get started, I would like to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session. The chat function will be available to you throughout the entire event, and we absolutely encourage you to use it to keep this session as interactive as possible. Please say hello, introduce yourself, and ask questions. We welcome hearing from you. Please note, AI note takers are prohibited to protect the privacy and the confidentiality of our instructors and participants, as well as the intellectual property rights of the content presented during the session. If you should try to add an AI note taker to the meeting, we will need to remove it immediately. This event is being recorded and be available for viewing in ACHE's learning management system in approximately two business days. Today's session is worth 1.5 hours of ACHE virtual interactive education credit. To earn this credit, you must be logged in for the entire 90 minutes of the event, and all attendees who meet this requirement will have their 1.5 virtual interactive education credits applied within 2 weeks from today's event. We do encourage you to complete the evaluation. Please visit the link in the chat box before we close out. I would now like to turn it over to Mark.
Good afternoon, everybody. My name is Mark Bonica. I am the Education Chair for the Northern New England chapter, and I want to welcome you all to our event for today. Really excited. I think we maxed out our number of registrations at 102 people. So I'm not sure how many we've got in the room just yet at the moment, but what a great lot of interest in this topic, rural health transformation. In my day job, I'm working on one of the contracts. So I'm intimately involved as well. So it's going to be great to hear three different states' perspectives today, and I'm going to turn it over to our moderator, Courtney Tanner. Courtney is the System Vice President of Community Health and Policy Affairs for Dartmouth Health System here in New Hampshire, and she's also our chapter president-elect. So thanks, Courtney, for moderating today.
Oh, I'm so happy to be here. And I'm equally excited and happy to be here with Kristen, Samantha, and David. But before I introduce them, let's set the stage a little bit for today's panel. I often say when we think about rural health transformation funds, we know when you see it in one state, you see it in one state. So we've been watching states kind of implement and design first and then implement in all different ways. And so we're really looking forward to digging in on our tri-state Rural Health Transformation Fund implementation. Across Maine, New Hampshire, and Vermont, our rural health ecosystem is facing some unique challenges. Our aging demographics, we share our aging demographics where we are getting older and colder in Maine, Vermont, and New Hampshire. We all are experiencing severe workforce bottlenecks. We have aging infrastructure. We have fragile operating margins across health systems, and not only hospital systems, but also our FQHCs, our community behavioral health partners, and the like. And we're really excited about potential opportunities that can be supported and developed during this Rural Health Transformation Fund window over the next 5 years. I think everybody has heard and knows the history of, but I feel obliged to remind folks that the Rural Health Transformation Fund was established in the One Big Beautiful Bill Act, signed into law on July 4th of 2025. We are over a year past that point in time, and it's taken CMS some time to allow for states to apply for and then for CMS to allocate funds to respective states. Many of you know that New Hampshire was awarded $204 million for the next 5 years, Maine $190, and Vermont $196 million each year for the next 5 years. And again, these funds are intended to really serve as an unprecedented opportunity where we will move beyond temporary relief and really think about building permanent structures and solutions for how we deliver healthcare in our states. All of our 3 states share some goals. We're going to hear more about that from Samantha and Kristen. and David. Certainly sustainable care access, a resilient workforce, and modernizing technology. And each state has structured an administrative engine and has funding priorities that are a little bit different because each operate in unique legislative spaces, different political spaces, and some different operational landscapes. And so we're going to break down how each of these states are going to be deploying their transformation funds. Just one more piece of information before I introduce our panel. We know that year one is rolling. Those funds were awarded at the beginning or the end rather of December of 2025. States have to obligate those funds and by October 30th of this year, and they have to be fully spent down by September 30th of 2027. Our three panelists are going to be responsible for, along with their teams, reporting those obligations and the spend down to CMS. And I'm looking forward to hearing their plans to be able to do that. So I'm going to introduce folks east to west because I grew up in Maine. So I'm going to take the privilege of introducing Maine first. Kristen McAuley is the Director of Rural Health Transformation at the Maine Department of Health and Human Services. Then we have David Chorney, who's the Director of Financial and Sustainability and Policy at Go North. And Go North is a newly established office in New Hampshire. It stands for the Governor's Office of New Opportunities and Rural Health Transformation. And so remember I said each state is administering their funds differently, and that is a structure that New Hampshire has established. And then in Vermont, last but not least, we have Samantha Hefferon, who's the Director of Rural Health Transformation at the Agency of Human Services for the state of Vermont. Welcome to the three of you. Thank you all for being here. So let's start with the big picture. And this is a question for all three of you. So whoever goes off mute first wins the opening mic. The $50 billion federal investment really is historic. I would note that the changes in the One Big Beautiful Bill Act, changes to Medicaid, were also equally historic. These were the first cuts, the first large sweeping cuts that we've seen and we will see and experience for the Medicaid program since its enactment in 1965. But this historic investment also comes with a strict 5-year window. How are each of your states balancing immediate needs, urgent rural healthcare needs that you've all been living with and experiencing with and understanding for decades now? How are you working to build a delivery system that can be sustainable after 2030? After that 5-year window?
I'm happy to jump in, Courtney, and sorry I'm not on camera. I'm actually up north, and for whatever reason, I'm at an EMS location for training, and I can't get onto the state Wi-Fi network, so I'm on my phone.
A bandwidth issue, one that
Yeah.
The three of you are working to fix, I'm sure.
Yeah. And so with that, we're looking at sort of a couple different phases of readiness that rural providers may be in, and some are in like the planning design phase, which could have it's hard to transform if you don't have stabilization. So can we stabilize rural providers with a commitment to invest also in opportunities to advance value-based care models or team-based access in primary care, or adopting other innovative care models that expand access or invest in population health initiatives. And then you have your other rural health providers or organizations that are in I'll use an example from this morning. We were talking to a bunch of municipal EMS agencies, and some of them have MIH or mobile integrated health programs, but they're looking to expand. And so they're in a different bucket. And so with them, we're working on how do we design a way to expand their existing MIH program in a way that also ties in a long-term sustainability framework with it. And part of that will be, a policy commitment from the state around looking at how do we get some multi-payer alignment for some of these coverage models or care models that we're trying to invest in through rural health transformation. And so whether that's partnering Medicaid with the state health plan or some of the larger health insurers or self-insured groups to invest in, some common alignment around how do we want to cover mobile integrated health or team-based primary care. So we've kind of broken it out from like our planning phase to a more expansion implementation phase, at least in this first year.
Thanks so much, David. So certainly hearing kind of multi-layers as you think about sustainability in terms of some investment now and also policy and system changes that can sustain work that's established now.
Yeah, I would echo much of what David said in the way that we're looking at kind of how you bucket these activities. Vermont has just about 36 activities or projects across our 5 initiatives, and you'll hear a lot in the RHG space, people call it things like shovel ready. And I think some of the things that David identified as those early actors would be considered shovel ready, or other programs like we are intended to expand. Some of our workforce initiatives are a little easier to get off the ground running, like providing financial assistance to students who are starting as early as this fall. So we're also taking a tiered approach in a way in how we're getting money out for year one, much like I think in all states.
Thanks, Samantha.
And I can add, I would echo that Maine is proceeding very similarly. I would also say that, especially in year one, and I think I'll talk a little about this a little bit later, we are looking at how we can make some significant investments to what Sam said of like that are shovel ready, that we know will help to stabilize the long-term infrastructure and services in our rural communities, while also advancing some of the more strategic innovations that we know will come. And so using it as, here are relatively significant amounts of money in the first year that will do that stabilization, but will also then be tied to future expectations, whether it is in regard to alternate payment models or technology innovation, et cetera. But doing so in a phased way that, again, allows for that immediate release of a significant amount of funding, that then leads into further expectations down the road. And that gets to, for some of our partners, they are more shovel ready to both receive the funds and make some of these transitions, and just have a better level of readiness versus some of our other partners or some of our other areas of the state that might still need more developmental support or just additional time and consideration to getting them to that place.
Thank you so much, Kristen, and thank you, Samantha. So we do already have a question in our in the chat from the audience, and I will promise everybody that I will not sing Schoolhouse Rocks, but I think it's always really important to kind of go take a step back and think about our 3 branches of government. We certainly, David alluded to some of the policy changes that his team's already thinking about working with our legislature. And I know that I suspect that Kristen and Samantha and their teams are also thinking about how can we ensure some sustainability in forthcoming legislation over the next few years as they work to transform healthcare delivery. The 3 of you are working in our executive branch. Again, I will not sing Schoolhouse Rocks, but we have a judicial branch that we're going to keep to the side here. And then you 3 are working in our executive branch. You've already raised up the legislative branch, but each of the states have different regulatory and other branches of their of that respective branch that you're navigating in. In New Hampshire, David, you're going to be working with our executive council pretty closely as you think about taking federal money in, having contracts approved. And so a lot of that work has happened with our executive council in New Hampshire. And Samantha, you'll be working with the Green Mountain Care Board maybe, and thinking about how to interact with them effectively. And so there was a question in the chat just around the Green Mountain Care Board.
Yeah, where they
fit into this.
Yeah, let me take a little bit of a step back to maybe give you like a better view of how we're managing the work overall. So everybody's government setup is different, and I won't make you sit through like how Vermont is in full, but the way that we approached managing our HDP is we didn't actually develop a whole new group like Go North, but our splitting up the management of these activities and initiatives across existing departments within AHS, and then also partnering with the Green Mountain Care Board to manage some of this work. And one of our activities under price transparency and insurance competition initiative is actually owned by Green Mountain Care Board themselves. And then we're also, collaborators and communicate pretty regularly about the ongoings of the RHTP initiative and activities. Is obviously healthcare transformation and what Green Mountain Care Board is doing are constantly intertwined. So they are an active participant and also taking the lead on at least one of our activities.
Thanks so much, Samantha. So so a perfect segue. You talked a little bit about collaboration within the state. Northern New England is pretty unique. I always marvel having, living right in the center of Northern New England. I get to go to Vermont in one day and I can go to Maine in the next day and still sleep at home both nights. We're highly connected. We all experience rural geography, and our workforce pool is pretty comparable, I would say, across the states. Where do you see the greatest opportunities for collaboration amongst the 3 states? Perhaps not yet in year 1, as you guys are all getting your bearings, but where do you think we could be collaborating regionally, sharing resources, rather than competing with one another?
I can take the first stab at this. I think in part, as Sam and I have been new to our roles, we often use each other as sounding boards and are really working to make sure we're connecting, across the New England states generally, of understanding how we are individually approaching early implementation and where there have been lessons learned as it relates to implementation, guidance on implementation, or things that we might be hearing from our grants project officer, and just being able to make sure that we are kind of collectively bringing those lessons learned together, that in a way that helps us, I can just speak for myself personally, it helps me feel a little bit more confident that, yes, I am indeed on the right path here. Because I think I've learned, this is new to states, but this is also new to CMS, and we're all collectively in this together. And so you do kind of sometimes need to learn things by your peers, formally, informally. And so I just really appreciated that we've been able to start that kind of ad hoc or informal networking, even if it's just right now focused on early implementation infrastructure, because they think from that then comes the really good foundation for, as we get deeper into implementation, what are some of those more programmatic, policy-based, more developed or advanced lessons learned that we can then contribute to each other, whether state to state or regionally. But it's nice to have that framework and that foundation starting to be established now.
Kristen, thanks for naming that and just really putting some time on when we all have new initiatives that we work on. Many of us expect to and want to be expert in that body of work immediately, and that's not always the case. So thanks so much for being authentic and sharing that with us.
I can echo, much of what Kristen said. I echo. We were just talking about this as a group before everyone else joined. And I think, admittedly, just due to the nature of this rollout, much of our focus has been inward, like getting the dollars out, meeting the new expectations, or not new expectations, but the, growing expectations from the collaborative agreement, making sure we're set up for success for our annual report and the NCC and all of the various parts of this award that we're looking to do in the first year. And so it really has been great to have these partners across different states, both David and Kristen included, where we can have those sounding boards. It's like, does this sound right? Have you asked this question? Should I ask this question? What are you doing here? And I think in future years, we'll continue to see opportunities, like Kristen mentioned, for lessons learned. How did you roll out? What is mobile integrated health looking like for you? I'm sorry, community paramedicine. How is workforce going? Where are you seeing successes here? We had a hard time connecting with this particular group. How did you do? So I think those are opportunities where we'll be able to really rely on each other in the future.
Thank you so much.
Yeah, I think that's right. I mean, at least for New Hampshire, initially, right now, everything has been on like getting the ball moving, and getting the whole. We're kind of like we've likened ourselves to a startup where we're getting everything off the ground and moving. And like the first big deadline for states is the deadline to obligate funds, which is the end of this October. And then you have until September of 27 to spend that first or invest that first budget period. And so we put a lot of time into trying to make sure we could obligate as much money as soon as possible, which was some of the strategic thinking around how we developed the hub framework, where so New Hampshire is leveraging 5 hubs to for our 5 initiatives to invest a lot of these dollars, and they'll essentially act as facilitating organizations that partner with rural providers to implement. And so we got the good news from CMS recently that we've gotten predominantly 202 of the 204 fully obligated, which is great news because it gives our partners at the end of the day that need to do the thing the time to plan and invest the dollars. But so a lot of work has gone into building that framework, and then I think the next phase around like implementation will lead to more opportunities to collaborate across states. But I think there's some in my mind like there's some areas where I think we really could collaborate on around workforce, because I know a lot of our community colleges share a border, and so they're pulling students from all the states. Telehealth also seems like a big one, where there could be some collaboration around scope of practice or licensing pieces, and reciprocity and things like that.
Great, thanks. So David, that actually leads me to my next question. You talked a little bit about New Hampshire's infrastructure in terms of establishing 5 different hubs. Can you, and thank you for the update around the CMS approval of the 202 obligated. That's great news. Congratulations. Can you share a little bit about what is the framework that New Hampshire has established in detail, why the 5 hubs, who the 5 hubs are, and I suspect folks are going to want to know where to look for opportunities, because New Hampshire has been a little bit slower in terms of rolling out the RFP opportunities, but that's because the framework was being built. So if you could talk a little bit about that, that'd be helpful.
Yeah, so I think the first question we sort of had to answer is how do we get all the money obligated? And you can do that through doing a whole bunch of RFPs, or you can do it maybe potentially in another strategic way of working with sort of ready partners that can act as facilitating organizations. And so with the direction from the governor, we took an approach and asked CMS approval for 5 sole source contracts, which are our 5 hubs, and they align with the state's 5 initiatives around population health, access, workforce, technology, and financial sustainability. And so our 5 hubs are, one is the Foundation for Healthy Communities, and they're really focused on access, population health, and financial sustainability. And they're really going to have the funding opportunities for rural providers to tap into RHT funds to stabilize and then transform, aligned with the state's RHT plan. So expanding access to primary care or integrated behavioral health, or expanding or developing new mobile integrated health programs, looking at EMS capacity and the time it takes to deploy an EMS unit in emergency in areas where, maybe it's 30, 45, 50 minutes for that dispatch to happen. What are ways in which we can sort of collaborate and partner and use RHT investments to solve that problem? The second hub is the Community Behavioral Health Association, and they're really focused on the state's community mental health system and transforming the long-term sustainability of that system. Right now, 3 of our community mental health centers are CCBHCs, but we're looking at a statewide adoption of that model. And then also investing pretty heavily in technology, and so developing a common electronic health record system. And I think some people have heard that and just thought all the CMHCs will just adopt or use the same vendor, electronic health records vendor. But what we're thinking is that'll be a single instance of an electronic health record system across all 10 CMHCs, rather than 10 instances of the same system. and then really investing in the workforce of the community mental health system to be able to adopt that open access integrated care model through CCBHC, which is also tied to a new payment model that's cost-based and prospective. And then we have 2 hubs around workforce, which is our university system and our community college system. And they're really looking at the pathway from high school to higher. So high school, associate's degree, bachelor's, master's, doctorate level. And UNH has a component of it that we haven't fully landed on what the exact name of it is going to be, but it's essentially a awards program that will help, that a student could apply for, and it will help offset the cost of whether it's tuition or other barriers that someone encounters to completing a degree. And then finally, we have the Community Development Finance Authority, which is really for people that are in the weeds in the grant. There are Category J funder, which is capital expenditures, or also what we've been calling as like bricks and mortar, but minor renovation, so no new construction. So if an EMS unit needs to renovate an existing facility to be able to do mobile integrated health, or a community mental health center needs to renovate some existing space to ensure community of care and open access. Two other projects we got approval for were to renovate county nursing homes to expand access to memory care units and preserve beds, especially in the North Country. So really trying to leverage all of that capital J funding for projects that will either expand access or lead to a longer, improve the financial sustainability of a rural healthcare provider.
Great. Well, thank you so much. And there was a specific question, which of the 5 hubs is dealing with assisted living and long-term care facility? But I suspect that it depends on what issue area that long-term care facility and assisted living are looking at, whether it's workforce or bricks and mortar.
Yeah. Yep. And the other opportunity where we're actually going, Courtney had mentioned the executive council. And so in New Hampshire, all contracts over $10,000 need to get approved by the executive council. And we have an item on the agenda next week for planning grants, and it's for our municipalities, EMS agencies, federally qualified health centers, rural dental organizations, and critical access hospitals to be able to directly draw down RHT funds from Go North to develop planning around how to leverage some RHT funds for transformation too. And we'll be doing some other procurements too. But our large strategy was to go through the 5 facilitating organizations.
Thanks so much, David. And Samantha, Vermont is made an announcement early last week, that your RFA opportunities are done for year 1. And so we provider organizations don't have to check the website so much anymore. But that you've been working hard to get RFPs out the door, and then the remaining funds will be sole source. Do you want to talk a little bit about your strategy and structure?
Yeah, so we took a little bit of different approach. We opted to go for year 1 more direct to providers or applicants. So across the 3 dozen activities, there's a mix of competitively procured and some direct award opportunities. And as of a week or 2 ago, all new notice of funding opportunities are RFPs, basically opportunities to apply for or bid for application, have been posted. There are a few that remain open still on our website. And I will say 2 large buckets have been extended for a round 2. You'll see that on our website. But as all of our activities have either identified an awardee already or have been up and open to people to apply. So that's exciting. Everything's out the door in terms of people know about it. And now we're really focusing on reviewing all of those bids to make awards, or it's across the board. So some are executed and obligated, some are routing for execution, some are still in draft, but really using the next few months between now and the end of October to obligate all those dollars and get them to the providers across Vermont. And as we start to obligate more those folks will be identified on our website. But I know that's usually the follow-up question, kind of who's been awarded. And once those are kind of moving more, we'll have a list on our website for people to check. But yeah, we looked into the kind of the hub and spoke model, or the hub model that David spoke about. A lot of other states we're doing something similar, and it wasn't part of our initial application. We considered it for the state of Vermont. It's still something that maybe we would consider in the future, but at least for year one, we really stuck to the initial application, or our initial model of posting many of these opportunities.
Thanks so much, Samantha. And it'll be interesting because each state will see what works and what doesn't work. So it's
yeah,
great
I think
collaborate.
Definitely. And I think, seeing how year one goes for folks will be really interesting. Yeah, lots of different ways to kind of meet the overall goal here. And I think there's no one right answer. Depending on how states are set up, there's different success looks different across the board.
So Kristen, Senator Susan Collins was actually instrumental in establishing the Rural Health Transformation Fund, and really worked on that after hearing from hospitals that they were concerned about the changes to the Medicaid program and the significant financial support reductions that hospitals were going to face with the changes in the Medicaid program. So Maine has chosen a different way of allocating its funds. Can you talk a little bit about your structure? It's my understanding that some of the funds are being administered by health systems.
So I was going to jump in, I think in part because one of the early lessons learned or approaches that we stole a little bit from New Hampshire was that kind of hub model. I would say we've taken a bit of a hybrid hub model that has a diversified approach to how we have really looked at funding. I think that early on, we really identified that the amount of competitive procurement that would be needed in year one was not necessarily feasible. And I think that gets to what Sam was saying of it's not just what success is, it's also what's possible within each of our state systems, some of which this is a lot of funding for a state to be able to take in. And so we have an approach that both utilizes some of our sister departments within the executive branch, as well as our independent or quasi-independent state agencies within the state, which is helpful. It's not just centered within DHHS. In particular, we really are able to work with Department of Public Safety, for example, for some of our community paramedicine efforts, for our Department of Education, for some of our early career pipeline strategies on the workforce development side, which has been really helpful, knowing that there's multiple partners that are around the table that will help to make this successful. We have also, for some of our funding that will be available to providers in particular, we worked with CMS to receive approval for who is an eligible provider in year one. We went through a process of identifying that based on where they are located in the state. And, for example, if they're in an entirely rural area, as well as looking at the fact that in Maine, we are a rural state. And generally, even if you are located, for example, in Portland, you are serving rural residents. That's just a reality of our state. And determining, okay, these are potential eligible providers based on where they are geographically, as well as then what type of provider they are, really focusing on hospitals, federally qualified health centers, and certified community behavioral health centers as some of the core early providers who would be eligible for some of our provider funding opportunities. And then having things go through a process that it wasn't necessarily based on competitive procurement, but identifying you are an eligible provider and you will be able to receive an award for each of the different kind of funding opportunities. So for example, we just released, we actually just opened under our Innovation and Technology Initiative application for EMR enhancements. So again, we define who is an eligible provider. And if you fell into that bucket, we determined about the award amount for some, math that we did around how many sites they have, rurality served, et cetera, and say you are eligible for up to X amount of dollars. You can submit an application for allowable expenses under innovation and technology, and you will receive this award. So it wasn't competitively based, but really looked at, okay, who are the providers that, especially in the first year, we want to ensure are receiving funds for this purpose and going through more of just a standard application process to receive the funding, rather than competing against one another, just because I think we were concerned that if we did put out, for example, a competitive opportunity for, 5 awards for EMR, enhancements, upgrades, etc., that we would get 100 applications in. And then it's like, well, how do you identify scoring and who should be prioritized for something, knowing that that's one area in particular for which there is a lot of need. So it was definitely something we struggled with in the beginning of which path do you go, but generally I would say we've received positive feedback for that. Okay, in that first year, we're going to really just say, this is our cohort of who is an eligible provider, and then work through a more straightforward application process.
Thanks so much, Kristen. There is a question in the chat from Donald centered on how will this impact hospital value-based purchasing, the hospital value-based purchasing program and its requirements. I don't know if anybody wants to jump in on that, but that is, as you all know, that is a program administered by CMS that adjusts inpatient payments by withholding 2% of base Medicare funding and redistributing that funding for clinical outcomes, for safety measures, for patient experience and cost reduction, and other. And so this might be separate from, but just want to raise up the question if anybody has additional information to add. Okay. Go ahead, David.
I would just say I'm not the expert for Vermont, but I'm happy to take that question back to our larger team.
Yeah, might be separate from. Thanks so much.
I think one of the ways we're thinking about it in New Hampshire is it wouldn't necessarily change the federal program, but I think RHT funds could be used to support hospitals and providers more successfully participating in those programs. So I think of like and I know it's not out there anymore, but like the Making Care Primary model that CMMI had, which was really like getting primary care providers ready to participate in value-based care models. And so I think that's a piece New Hampshire is very interested in supporting our rural providers to be able to then participate. And so whether that's like technology to support the population health data analytics and risk stratification, or investing in initiatives, internal operation initiatives that would like lower the cost structure for a hospital so that they would be able to better participate in shared savings, is all I think fair game.
Yeah, great. Thank you so much. So let's dive into some of the substance. David, New Hampshire, while this is certainly not a dart, not throwing, they've been slow to roll in terms of RFPs. I think that we're going to see RFPs rolling really quickly in the next several weeks. But there was an initial RFP that was rolled out at the Foundation for Healthy Communities that's going to be focused on stabilizing and transforming emergency medical services. I think you're actually up in the North Country working on some of that right now. Can you talk a little bit about the target areas for New Hampshire's impact strategy, and what are some milestone successes just in year one?
Yeah, so that funding opportunity through the foundation is really focused on, I think there's really 2 components to it. There's a piece around what we've called stabilization funding, which an EMS agency could use to, whether it's a piece of new equipment or something that's sort of been on their wish list to help them, provide better EMS services, they could tap into that funding opportunity to purchase that under the idea of stabilization. And then the other piece is either if they want to develop a new mobile integrated health program, maybe they're not doing mobile integrated health right now, but they want to, or they have an existing mobile integrated health program and want to expand it. And so we've heard of some ideas around like expanding mobile integrated health in the North Country to try to address some of the OB and maternity shortages. And there's a whole bunch of other innovative ideas folks have. And so that's really that opportunity. And we've paired that with we know that there's a lot of volunteer EMS agencies in New Hampshire that maybe are not quite ready right now to be able to access that funding. So that was part of the reasoning of developing that planning grant that I had mentioned earlier, where they'll have the opportunity to get up to $50,000 to help submit a plan and be able to access funding there. And the sort of core outcome we're really looking for in mobile integrated health is reducing avoidable ED visits. And then connecting them to the appropriate level of care in the community, whether that be primary care or in some cases it could be care at a community mental health center. And so that's kind of the core objective. And then the long-term sustainability piece is right now in New Hampshire, Medicaid covers treat no transport when the call comes in through 911. But if it doesn't come in through 911, which happens in mobile integrated health programs, there's very limited payer coverage. And so working with Medicaid to change the coverage for mobile integrated health, and then sort of partnering with other payers, whether that be the state health plan, to align on a common strategy around reimbursing mobile integrated health.
And what other buckets or priority issue areas do you want to raise up in addition to mobile integrated health or emergency ground medical transport?
So in the EMS space, we also have a interfacility. Part of our project narrative or CMS approved plan was to look at how interfacility transports happen. And so working with hospital-based EMS programs and transport agencies and non-transport agencies to help develop a more regionalized system on that front. But quickly following the EMS is just our first funding opportunity. There's one that will be dropping soon around school-based oral health. And so expanding access to dental care, particularly prevention dental care in school settings. There's a primary care one that's coming, and also one for the critical access hospitals or rural hospitals. And the primary care one is really focused on expanding access at a team-based care level and supporting rural primary care providers to develop the ability to participate in value-based care arrangements.
Thanks so much. Lots of exciting things to come in New Hampshire.
Yeah. And some of it is unique, like some of the workforce stuff through the community college and the university system don't necessarily lend themselves to like what I think people would think of as like traditional RFPs or funding opportunities. So the university system's building out a statewide clinical simulation framework. They have an RFP right now for augmented and virtual reality. I don't think it like is garnering the interest, right, of that like the EMS or primary care funding opportunities will. And then the community college is really focused on hiring and staff and expanding the number of people that can graduate with a credential. So it's just different ways of using funds.
Thanks so much. Kristen, if we can turn to Maine. Maine has carved out specific buckets for its year one plan. $30 million for EMR modernization. You talked a little bit about that. 28.5 to modernize transitions to alternative payment models. Kristen, how do you see data interoperability and value-based care working hand in hand to stabilize your most rural and vulnerable hospitals?
Yeah, no, thanks for that, Courtney. I would also say, so I touched on just a few moments ago the electronic medical record funding opportunity that we have. We also have another one, which is almost $30 million, which is looking at among our hospitals, our federally qualified health centers, and our certified community behavioral health centers, really looking at how we can continue to use our HTP funds for continued transitions to different alternative payment models. Under the current administration in our state, we really have had that as a pretty significant policy focus and practice focus led out of our Office of Maine Care Services or our Medicaid office. And then in addition to that, we also have a third funding opportunity, which is really looking at a couple of handfuls of our rural hospitals, most of which are critical access hospitals, and those that are really struggling both from a potentially financially as well as from the electronic systems they have, which support their work and their ability to really implement and undertake some of the APM transitions in particular. And so those three funding opportunities, that constitutes almost 50% of the funding that we'll have in year one. That will change in subsequent years. But we really were intentional about thinking at, for these, for such a significant amount of money for the state of Maine, how this money can be utilized by some of our providers that we know are in some of our most rural areas to be able to have the infrastructure they need, kind of what I said at the beginning, in order to be able to take on some of that really innovative and transformative care that we know we are driving towards in subsequent years. I was listening to some of when I was first stepping into this position, and our hospital association for the state had done just a preliminary kind of understanding of where, for some of our hospitals, where their information technology infrastructure was. And, for one of our rural hospitals, they really haven't had a significant upgrade in like 20, 30 years. And so when you think about what is needed in order to be able to do population health management or some of the other different types of payment models, you need to be able to have that data infrastructure behind you. And so while there's three different funding opportunities that we have, they are connected with each other and really do support each other over the long term, especially for some of our hospitals that we know have been particularly challenged from both a financial infrastructure standpoint, but being able to have that investment in the systems they need for some of the change we're driving towards.
Thanks so much, Kristen. It's really helpful. Turning to Vermont, Samantha, you've alluded to this a little bit, but Vermont has a deeply rooted history in healthcare reform. In fact, I know that some of our healthcare colleagues across the country look at Vermont to say, what are they doing over there in terms of value-based payments or exploring an all-payer system, et cetera. So Vermont's often one that we look at, particularly when it comes to global budgeting and the like. And the Vermont's Rural Health Transformation Fund plan had 35 distinct activities across strategic initiatives. You talked a little bit about leveraging that plan, but can you give us a little more information on how this existing reform infrastructure fast-tracked these new dollars for you to really invest in the rural communities, and particularly with the workforce pipelines?
Yeah, I think the way I would say it is it's not necessarily fast tracking getting those dollars obligated and into the hands of providers, but more that it gave us a sort of like solid roadmap on what we know we want to do, and that is informed by all of the work that my colleagues and people before us have put in to identify really like what the key opportunities or challenges that Vermont faces are. So this kind of ties back to what we originally were talking about, but some of the work that Vermont has already done in the transformation space, having programs that were able to expand or a little bit more shovel ready, or maybe where you would see more of that fast tracked opportunity. But really it is like the groundwork was laid. We know what we want to do, and can we identify the partners in which we can do this in a quick way. And you want to know a little bit more about like what we're doing in rural workforce pipelines. Is that your question?
Yes.
Yeah. One of the first activities, actually, I think it was the first activity that we obligated, was working with our partners at BSAC to create a financial assistance program for students to receive funding for opportunities to get degrees or be certified in healthcare professions. And so this is funding they would apply every year, but it's full tuition funding for those students. We also know that there's a need across the board, both entry level and some of those higher level programs or positions in our workforce. And so we're expanding on an statewide LNA training program, and we're also in the works of opening up and helping start, I would say, the rural family medicine residency program in Vermont. And so we're really trying to look at kind of like how we're able to impact the workforce kind of like from all angles. I think one of my colleagues talked about the kind of like high school to higher pipeline. I think that was you, David. And I like that messaging. I think we have programs, not necessarily all of them on that that tracked, but programs that are looking at some of our youngest and our earlier students to those that are maybe already in the workforce and have opportunities to get additional training. And so lots of opportunities trying to cast a wide net to make sure that we're also increasing the pool of workforce that we're able to tap into for our rural communities.
Great, thank you so much. And I'll have more workforce questions, don't worry, because I know that's of interest to many folks on the call. But I do want to pivot to Kevin Curtis's question too. He's got two questions. And David, it looks like David's coming off mute, so that's good. The one specifically outlined to you, what's the best way to know about opportunities that are coming down the pike? Again, Samantha, you're a little bit off the hook because we know RFAs are done in Vermont for year one. But as you're thinking, Samantha and Kristen, about year two, what are remaining opportunities to propose programs or engage with your respective offices to highlight maybe innovative programs or projects or areas of opportunity that might not have been aligned with year one and might fit better in year 2, 3, or subsequent years? Kevin, I hope I captured that okay. Thanks, David.
Perfect. Yeah. Hey, Kevin. So two things. The best place or best way to stay up to date on things we're working on is to sign up for to receive notices from the Go North website, the listserv. And then I think there are two pieces of guidance or documents from two of the hubs that'll be really helpful. So CDFA, the Community Development Finance Authority, put together a program guide around sort of what are the priority provider groups. So EMS, rural hospitals, FQHCs, community mental health centers, and what are the types of projects they're looking at, or is Go North looking at for that minor renovations bucket. And then where I think it'll be today, it may not be till tomorrow, but the foundation is also going to be publishing a similar type of program guide that I think will be really helpful for rural hospitals, primary care, EMS, and really rural providers that would access funding through FHC. And that program guide will have a description of what the upcoming funding opportunities are and some of the initiatives and goals that we're looking for to see. And I think you got a second part of your question around if there's been some new thinking around new ideas that could be supportive to achieving the outcomes in the state's plan. The way we're trying to do the funding opportunities through FHC is to create enough structure so that folks know what they're applying for and what the requirements are and what the goals are, but also to create the ability to still be creative so that we're not locked into exactly what may have been thought last October or November, since we know a lot has changed since then.
Great. Thank you, David.
No problem.
From the verb.
Oh, I'm sorry. Go ahead, Courtney.
Go ahead, Kristen. Jump on in.
No, I was going to say, I would also say that over time, we do not anticipate that all pieces, I would imagine for any state, will remain static. There is this, what was possible in year one from both an administrative as well as just operational readiness. And that will, we know that will evolve over time. We're in the midst of planning to submit our year 2 application at the end of August. As part of that, we're holding listening sessions with some of our partners to identify, even though we're only what feels like a handful of months into implementation, what are some of the pieces that we missed? And so I was on a call earlier this morning, for example, with our Maine Primary Care Association, which is our member association for federally qualified health centers. And we had a very frank conversation around, pharmacy is an area that was not necessarily in year one. And how can we think about where there are some natural opportunities that exist right now that can be leveraged, especially as it relates to access for one of the initiatives that we have. And it doesn't mean it's necessarily going to make it into the year 2 planning, but it's just helpful that knowing that things will change. And what's important is to be able to have some of the forums for those conversations to happen. So we have an advisory committee for which we sometimes feel like there's a lot of members. I think there's about 35 members, but we wanted to make sure that different partners across the wide spectrum were at that, and then continue to have these kind of smaller groups, especially with member associations, to have those feedback loops of what are we missing, what's going well. And I think in part because Maine isn't a giant population state, we're able to have that dialogue, that feedback based on just a lot of our existing relationships that we already had well before our HTP, and value those perspectives as we move forward to say, what are we missing? What are some of the areas for which we really need to be more intentional, and sometimes probably just needed a little bit more time, weren't able to launch in year one for those reasons.
Thanks, Kristen. The idea of an advisory group is a really interesting one. 35 members is large, but that's interesting. Seems to be comprehensive. Samantha, did you have something you wanted to add to?
I think just the second part of the question about what can we expect for year two. We're all actively submitting our annual reports and our basic NCC, which is basically sort of like our reapplication. All that to say, in October is really when we'll find out what our year two award really looks like. And I would say for Vermont, year two, there are some activities that didn't take off right away and like Louisville year two activities. But additionally, some of the work that we're going to need to do is to identify some of the awardees that will already have received awards. What are like one-time fun things that they will not necessarily need to see in year two or three, et cetera, and what are dollars we're going to need to continue to move forward. And all that to say is that some of our activities, I think, will be likely opened again for additional awardees, based if we continue to see the same award total or more, and some of them might be more like continuation of those who are already identified partners. So I think the kind of like what will year two look like is a little bit of a to be determined, but likely some kind of mix of that. So potential new awardees, potentially new programs we didn't start up already, continuation of award for some existing partners.
Great. Well, thank you so much. And that has been some critique, particularly here in New Hampshire, around year by year funding. It's difficult to build business plans when you have just 1 year of guaranteed funding. So
certainly,
yeah. So thanks for noting the subsequent awards potential. So I just want to, for all participants too, I just want to invite, please feel free to raise your hands or throw your questions in the chat. Really hopeful that this is a useful time for all of you. We've got 3 experts and implementers here, so please feel free to ask questions and either coming off me or throwing them in the chat. I hope I'm keeping up. There is another question before I pivot to my workforce question centered on area health education centers. Can you talk a little bit about AHECs? If you have plans for our area health education centers, where do they fit into your plans, and what could funding design look like for AHECs, if at all?
I can share this. This is very early in development, but one of our population health activities really looks at the expansion of community health workers throughout the state, both geographically as well as within our tribal health centers. And some of the CHW focus within Maine has been within our AHEC at the University of New England. And so we're just starting to have some early conversations around how to make sure some of the historical work undertaken, especially around the community health workers, is leveraged as part of what is then an expanding activity to ensure the presence of community health workers in, throughout the state, and just bringing that partnership to the table, even if it's from a thought partnership perspective, to ensure that as we build out this activity, it's informed based on the work that has already happened in the state and within that AHEC in particular.
Yeah, thank you. That's really helpful. Well, let's stay on workforce for a little bit, because workforce has been is a challenge for Maine, New Hampshire, and Vermont, of course. And we are all struggling to ensure that we have enough workforce at all levels of our institutions. And there has been a lot of talk about how to build pipelines, but we do have lean workforce development across our 3 states. I know that there's been a lot of planning and thinking about that. Can you talk a little bit about some creative strategies that you're either deploying or plan to deploy to ensure that we're not just cannibalizing existing workforce pools, but that we're really building out and supporting and developing new workforce in addition to retaining and developing our current workforce?
Kick us off. And this is definitely an area that does not come from my previous experience, which is more on the public health side. But we do have, in Maine, we have a partnership that really started with some of the COVID and ARPA funding received that really looks at how there are early career pathways or early career pipelines that include work with our regional technical schools within the state. And so I think there are about 10 regional technical high schools within the state, as well as our community college system for what are some of those early career credentials and training opportunities that, Courtney, to your question, really that is identifying individuals who are from our rural communities who want to remain in our rural communities and identifying what are some of the training opportunities that will help them to do that and really help them to start down a career pathway that then can lead to whether it's stackable credits or additional educational opportunities that I think for me, that's like homegrown opportunities for us, and especially for some of our younger Mainers in rural areas, which we know oftentimes our younger Mainers leave our rural areas to go to the more urban places. And so when they have these meaningful opportunities within their communities, we know that it's successful. It's a great outcome for all. Some of that work has been somewhat slowed just based on the expectation of a 5-year rural service commitment that is associated with the receipt of some of these funding opportunities. I think that that's something we've gone back and forth with other states as well as with CMS of how can we ensure that these funds are still able to have this amazing investment from an educational standpoint in our rural communities without putting people, especially younger people, at a place of committing to something that they might not fully be able to. And I think that that's still an area that we are working to make sure we are doing so with the intent that is needed, with the transparency that is needed, and with the support of CMS. But I also don't think it's not like we're going to just completely walk away from these opportunities, because they really do represent such a critical component in workforce for our rural areas and our rural younger Mainers as well. So that has been exciting to see. And I think will continue to evolve as states collectively understand how best to meet, really uphold what CMS expects around service commitment, but doing so in a realistic manner.
Thanks, Kristen. Samantha or David, do you have pieces around workforce that I know in New Hampshire, David, you have 2 specific hubs that are Mark is working on the hub at UNH in our university system, and then of course our community college system.
Yeah, New Hampshire's plan or idea was really to try to create a pathway that can start at the high school level. So similar to, I think, what we just heard from Kristen in Maine about the technical education centers in New Hampshire, they're called CTEs, investing in those to be able to, some of them have closed their healthcare related programs, but bringing them back online and using as a way not require the 5-year commitment for students that go through those programs, trying to invest in sort of the infrastructure needs to be able to support those programs, whether it's additional faculty or maybe it's equipment, or maybe there's some space that needs to be renovated so that they can actually have the class there, and then creating the relationships with the provider organization so that they can get some clinical experience, but then also partnering that. So that's actually part of the scope of the community college system because there's a really logical connection between those high schools and the community college system there. And then we also have at the other end, and Mark knows this, the university system, so that someone could go high school associate's degree to a bachelor's degree, or up really up the chain. And the thinking is, if there's relationships with the provider organizations, you can have these sort of self-fulfilling cycles where someone enters the workforce, gets some experience, wants to go up the ladder, and can leverage these different RHT tools or opportunities to then get those advanced degrees. I think sort of a lot of the work Dartmouth has done with River Valley College in the rural healthcare careers, I think, is a really good model to try to replicate and expand as well.
Great. That's really helpful. Thank you so much. New Hampshire will be first in the nation, is poised to be first in the nation to have 100% broadband coverage in all homes, or available to all homes.
Yeah.
There's a question in the chat around infrastructure specifically for communications, because we know we're all thinking about telehealth, we're all thinking about e-consults. Do you all want to talk a little bit about opportunities or potential risks or barriers that you're thinking about and navigating as we think about innovative care? Doesn't have to be all sunshine.
I think one of the barriers, just the rules around how states can use RHT money, and I'll use telehealth as an example. Like, we can't pay for the internet access, so the availability of broadband may be there, but it may be inaccessible due to a cost issue. And so I think one of the things we've been looking at and talking with different communities and providers with is, are there places where we could create like a telehealth access point within a community, whether that's at a library or a town hall or a senior center, where you can make the telehealth available and sort of get around that prohibition on not being able to pay for or cover the cost of the internet access. But I think that could be a barrier, and especially maybe in the remote patient monitoring, where a lot of those devices will probably need to be connected to the internet somehow. And how does that work? And I don't know, maybe there's part of it that can be used through Starlink. I know the state's looking at that for that. I think there's like a very small number of homes that still need to get access to broadband. But we're also having conversations with the Bureau of Economic Affairs and other state agencies within New Hampshire, because I think there's opportunities where funding can cover things easier than RHT can. And so how do we pair that together where it makes sense?
Stretch the opportunity. Yeah. Samantha and Kristen, do you want to raise up concerns or opportunities with your communications infrastructure and or digital literacy for populations? We got health literacy, digital literacy. Is a lot to navigate for in terms of access.
I can't talk a lot about our communication side. That isn't something that is prominent early on in our implementation. We are looking at pieces of digital literacy, both as it relates to work on our innovation and technology initiative. That is something that one of our partners, Medical Care Development, or MCD, will be releasing some opportunities to really think about what are some of the tools that consumers can use to improve health literacy, improve their ability to navigate healthcare, et cetera. And then we will, over time, also work with our Office of the Health Insurance Marketplace, which is an office within our Department of Health and Human Services, to look at how their enrollment platform can also be more easily understood as it relates to the different health insurance options, et cetera. So I would say neither of those have a significant footprint within our early plan, but we are slowly building them out from a couple of different areas.
Thanks, Kristen.
I think the activities in our price transparency and insurance competition initiative, which is the long title for that one, are pretty similar to kind of what Kristen was saying, aiming to, obviously it's in the name, but like provide more transparency on what things cost and how can we kind of present that information in a better way to Vermonters. in terms of shared services or like the telehealth space, many of our activities were many of the ones that were competitively procured and are sort of still in flight. So I don't want to speak on them too directly, but I think that we tried to think of ways to approach these in different ways. So maybe more of like a statewide platform or approach to help break some of those financial barriers in more rural areas, while also trying to not necessarily like steer everyone into one particular option. And so some of our other shared services and telehealth activities are more like gave the providers opportunities to find what tool might actually fit their specific needs. So that's not necessarily answering the question that you specifically asked, but I
That's
think
okay. Information. Yeah.
Yes, you'll see those probably being finalized, at least for the first round in hopefully the next few weeks. So we're excited to get those dollars out.
Great, thank you so much. And Donald put a note in the chat. The Universal Service Administrative Company provides funding for rural healthcare providers to build out broadband and will cover some equipment. That's a great resource, Donald. They also have a Lifeline program that can assist with funding for internet access. So thanks, Donald, so much, and for all of the questions that you raised up.
I think the Category J funding that David mentioned earlier, which is like we call the minor renovations or our facilities grant, is a good way to maybe offset some of those costs as well. So we aren't able to pay directly for broadband, but maybe some of the other upfit that's necessary for that infrastructure or just general, again, minor renovations. That one is one of the particular categories that we have to work a little bit more closely with CMS, but potentially a way to offset costs so that providers should cover the pieces that are unallowable on their own.
These funding structures are really puzzles. So I'm only grateful for that because it's good job security for me, but that's the only reason why I'm grateful for that. Pivoting to a broader question, if there was one particular lesson or policy shift that one of your colleagues, Samantha, Kristen, or David, your neighboring states, either the plans or your policies were utilizing, what would you look at to say we need to find a way to adopt that? What's something that you're stealing from one another or borrowing from one another, in addition to some of the ones you've already raised up?
I think right now, and not to like repeat what we already said, is it's a lot of like getting the ball going and getting started and stealing from we've all kind of like stolen pieces around like how to structure procurements. I know we've done some stealing from other states on how are they structuring like the provider transformation funding for primary care. And then even just like the structural internal processes around like what do you do to meet the CMS requirement that really nobody wants to hear about because hopefully it just stays within like state government and is simple enough to like we can carry that water so other people don't have to.
Well, David, I think you're alluding to one of the questions that's in the chat, and I wasn't going to go here because I live too much in the weeds on this, but there are requirements and parameters around this funding: salary caps, indirect cost. And so how are you all navigating, and what guidance are you giving at a very high level? I know we could do a full hour on this topic, but at a very high level, how are you navigating clinicians' salary support and the like for direct programming?
So yeah, clinical salary support, I think it's a really nuanced question, particularly around some of the limitations states have on how they can use provider payments. And so provider payments is sort of a broad funding, but potentially funding to fund services, but it can't duplicate existing reimbursement. So if it's a service that's coverable by, say, Medicaid or Medicare or commercial, you can't then add on to that reimbursement rate. And there's also a salary cap that all states are required to comply with that I think is like $225,000. So for some of those clinical salaries, like they'll be above that. But I think there are ways to potentially use provider payments as like an incentive tool for certain programs that then don't fall into sort of the like increase in a fee schedule reimbursement amount. And then there's also the way New Hampshire is really looking at using them is to support programs that currently don't really have a funding source. So mobile integrated health is a good example in New Hampshire where there's not really good coverage for that. And so we can use the provider payments for that. But it really is a like a budgeting puzzle because that provider payments category is capped at 15% of the state's award. And so and also not knowing what your future funding amounts are going to be because it changes each budget period with CMS. When you try to like look at a 5-year plan and budget that out, it gets pretty complex. And then there's other caps around administrative costs and indirect, which I know New Hampshire has faced, and I'm sure Maine and Vermont has faced similar questions. Like there's been a lot of confusion around, well, what about administrative costs aren't really defined under federal uniform guidance, which is the cost principles. And so generally people think of like, is it a direct cost to the grant? And that's permissible. And then you have your indirect costs. And within RHT, they've thrown this other curveball, which also caps your administrative costs. So administrative costs and indirect costs, two different things in aggregate are capped at a state's 10% of their total award. And so trying to create a structure so most of the funding that goes out through Go North or the hubs is for direct programmatic costs so that we can stay under that threshold.
Thank you. It's that was a really great high level. I see Kristen nodding her head. I see Samantha smiling. So it was a really great
None to
high
add.
level.
No notes.
Yeah. So we have I'm looking at our participations. I suspect at the hour we lost a couple of people, but we have about 60, 70 hospital CEOs, practice managers, healthcare, community health leaders listening in today. What is the single most effective way an individual healthcare organization can align itself with your state's Rural Health Transformation Fund roadmap? What advice departing advice would you give our listeners today?
I would start with our website. We're continuing to build out ways that we're engaging in external stakeholder communication, but the website for Vermont is going to be the place where we'll likely announce that, where you'll see our updated project narrative, our any changes to awards, awardees, opportunities for funding, applications. We also have a link there to get to our listserv. So that's the place that I would say to start.
David?
Yeah, I mean, definitely stay in touch with the Go North website because that's the best and fastest way to make sure you have the most up-to-date opportunities. I sort of keep thinking about this dynamic, the overall like healthcare economic marketplace that's sort of playing out right now. And so I think, thinking from a more systems level, I would be thinking about like what are ways in which I can use rural health transformation money as a catalyst for change within my organization that helps reduce maybe the overhead cost structure or long-term cost structure of the organization, but preserves, access to essential service lines. So what's your current barrier to investing in, maybe there's a low quality care area that you want to address. And so what's the barrier to making that a high quality or more coordinated care? I just think through like the way somebody accesses care today is very uncoordinated. And so, as you're looking through the system, larger health systems and how someone interacts with that system and where your referrals come from, how can you use RHT money as a catalyst to be a little bit more efficient and streamlined?
Yeah, I would echo both Sam and David, and I really appreciate, David, how you were teeing things up, because I do think, especially early on in implementation, we don't get this as much anymore. We, as this, as the prime recipient, were received a lot of, I have an idea, how can I get funding for this? And, I understand that's a very natural question. And I think what we've really had to say is, here is how Maine has approached this significant opportunity. and there will be opportunities within it, but it's not as though we can just take in what are very good ideas from some of our partners around the state and try and integrate it into something that we've already built out a plan and an infrastructure for. So David, I completely agree with, like, if there are needs, how our HCP can be leveraged as a catalyst to launch something that aligns with the plan that we have as the state. Because I think that there's such opportunity for that leverage and synergy. And it's only when we're able to have those conversations together of where do those opportunities, what does that look like at the local level, that we're then able to make sure we're incorporating that in our state plan. But it is hard if we continue to get one-offs. Like, it's not disrespecting those ideas, but again, it's not necessarily easy to integrate that into our plan. So even just familiarizing yourselves with the state plans and where there are opportunities, I think is also just very helpful.
Thanks so much, Kristen. I want to take just a couple minutes just to say thank you so much to our panelists, because David, Kristen, Samantha, you all have extremely busy jobs right now. Many of you have very, very small teams, if not all of you have extremely small teams, and are responding to the wishes, desires, and needs of the entire state that you're serving. So thank you very much for being with us and for your time with us here today, and for being so open. It's not always easy to take questions cold from the audience. So thank you for your willingness to do that, and for joining us today and informing all of us on not only the current events with regard to rural health transformation funds in our states, but also looking ahead a little bit too. So a sincere thank you to all three of you.
Thanks for having us.
No problem. Thanks for having us.
Mark, I'll turn it over to you.
Great. Courtney, thank you for helping organize such a great session. Thank you to our panelists. I hope you all found this session valuable. We generally have sessions every month. So if you're not currently getting our newsletter, just shoot me an email. And hope to see you at our November annual meeting as well. All right, thank you. Rachel, over to you. You're muted, Rachel.
Sorry, thank you. On behalf of ACHE, I want to thank our chapter leaders that planned today's session, our moderator and panelists, and all of you that participated. Please complete the evaluation, which is open for 1 week. The direct link is in the chat box. You can also access the evaluation by visiting my ACH page and selecting My Online Learning from the Helpful Links section on the right side of the screen. From there, click on My Access Courses link, and you will be directed to the learning management system where you can complete the evaluation. In the same location, you will be able to access the recording of this session within approximately 2 business days. Everyone who attended today's event in its entirety will see 1.5 hours of virtual interactive education credit posted to their My ACH account within 2 weeks of the session in the My Education credit. That concludes the session that is copyrighted in 2026 by the American College of Healthcare Executives. All rights reserved. Thank you, and everyone have a great remainder of your day.